Hello students, welcome to part 2 in this chapter named Concepts of Care for Patients with Problems in the Nervous System, especially the brain, and we are covering part 2 of Alzheimer disease. So there are 4 important facts that we need to consider for nursing care for Alzheimer disease patients. So one is decreased memory and cognition. Number 2, potential for injury or falls due to the wandering or inability to ambulate independently. Number 3, potential for elder abuse by caregivers. And number 4, potential need for symptoms management at end of life. So I am following your PowerPoint. If we will follow only the PowerPoint, we will miss all the details that are going to be listed now. Okay, that's why it's important to read your book. Fact number 1, managing memory and cognitive dysfunction. So the desired outcome is to maintain memory and cognition for as long as possible, and we can achieve that by exercising the mind, reading, or nutritional exercise and stress management. That's part of the lifestyle changes, right? So interventions, although drug therapy may be used for patients with AD, non-pharmacologic interventions are the main focus of nursing teamwork and interprofessional collaboration. Okay, teach family members and significant others about the importance of being consistent in following the patient-centered plan of care, and that's good to know. So besides the pharmacological, we have other interventions. For example, the patient with memory problems benefits best from a structured and consistent environment. That's good to know. This is NCLEX alert, okay? The patient with dementia frequently has other health conditions. Changes in vision and hearing also may be present because all of them are related to our brain function. Okay, think about your cranial nerves, right? Think about if this is a vascular dementia, think about those little arteries and veins, small circulatory vessels in the brain that are related to the vision and the hearing. And if they have atherosclerosis of bad glucose metabolism, those little arteries are going to be full with cholesterol and sugar. So of course they're going to have health issues in the vision and hearing. Approaches to managing the patient who has AD include cognitive stimulation and memory training. Yes, structuring the environment, orientation or validation therapy, promoting self-management, promoting bowel and bladder continence, promoting communication. So the purpose of cognitive stimulation and memory training is cognitive stimulation is to show a video of family members to the patient with dementia to manage behavior or help improve memory. That's an exercise, right? For example, in addition, advise the family to reminisce with the patient about pleasant experiences from the past. Use this technique, this therapy, while assisting the patient with ADLs or performing a treatment or assessment, right? In some long-term care or memory care units, a picture of the patient is placed on the room door to help with facial recognition and to help patients locate their room. So they see their face, they know that's the room, because you don't want the patient to get into the wrong room. Maybe if the patient is a male, is getting into a female room. It could happen, right? This picture also helps the staff locate the patient in case of wandering or elopement. Teach the family to keep environmental distraction and noise to a minimum. In addition to disturb sleep, other negative effects of high noise levels include decreased nutritional intake, changes in blood pressure and pulse rates, and feelings of increased stress and anxiety. Nursing safety. NCLEX is all about safety. Safety. In a new setting or environment, collaborate with the staff and admitting at department to select a room that is in the quietest area of the unit and away from obvious exits. Yes, if possible. A private room may be needed if the patient has a history of agitation or wandering. Or, based on my experience, they can develop agitation and wandering after admission. Okay, so you need to follow these patients. They can go from one symptom to a worse symptom in minutes, in hours, in days. As I told you, they don't need to follow the 3 stages of the Alzheimer's disease. They go from early stage to the late stage very soon, very fast. Objects such as furniture or hairbrush and eyeglasses should be kept in the same place. Explain changes in routine to the patients before they occur. In validation therapy, the staff member recognizes and acknowledges the patient's feelings and concerns. For example, if the patient is looking for mother, ask about what mother looks like and what she might be wearing. As the disease progresses, altered thought processes affect the ability to perform ADL. We know that. Encourage the patient to perform as much self-care as possible and to maintain independence in daily living skills for as long as possible. Think about this. Usually, and you have to be we have to be honest, right? When we observe the behavior of our grandpa or grandma, they basically they are not doing their they are not taking care of their hygiene, right? The full in the full way. They are sometimes skipping washing their hands, or they just open the sink and just put the hand below the water just very quickly. They don't put soap and do the hand washing like we do, right? So if they are not having AD, can you imagine how the AD patient is going to behave? So think about that. Interprofessional collaboration, you can read about this. And we have another NCLEX question. A client with moderate stage Alzheimer's disease. Moderate stage. In a memory care unit appears to be frightened at the assigned dining room table. What would be the nurse's most appropriate action? And even though the action probably is going to be move the client to another table, because it's a validation therapy in which we recognize their feelings. If they are frightened, then we are going to move the patient to another table. Also, I would say we need to assess the surroundings for sensory stimuli. That's very important. I will think about it. Probably, I'm not going to include this question in the exam because I think it's kind of tricky. Okay, but think about it. Maintain a clear path between the bed and bathroom at all times for patients who are too weak to walk to the bathroom. Okay, and that's good to know, because we need to prevent falls. Now, best practice for patient safety and quality care promoting communication with the patient who has Alzheimer's disease. Some important points are validate the patient's feeling as needed. Whatever the previous question was a perfect example for this. Limit choices. Too many choices use frustration and increase confusion. So, for example, that patient that was frightened because he didn't like that dinner table, you're not gonna tell the patient which one do you like the most, or you prefer table 1 or 3 or no. You just move him to another table. Limit the choices. Never assume that the patient is totally confused and cannot understand what is being communicated. Okay? Complementary and integrative health. Teach the patient to provide the assistant provider, who's the AP, teach if cultural teach AP to provide massage. Okay, the the person who is gonna provide a massage before bedtime to promote sleep, or at other times to reduce stress and promote relaxation. Aromatherapy works wonders, if you ask me. Animal assisted therapy, art, and group activities are an important part of behavior management. Music has shown strong results in overcoming apathy and improving cognitive outcomes, especially if you are able to match the patient's culture, origin to the right music, right? So, for example, if you have an African American patient and you put kind of soul music, he's gonna be happy, right? Especially if you put music from, depending on the age, right? Music from 40s or 50s. For example, if you find a patient from for example, a Hispanic patient, right? A Hispanic patient, and he's able to remember Luis Miguel, which is a famous artist from our culture. So you need to match the age of the patient, the culture, the origin of the patient with the appropriate music, right? A white patient with white from white origin probably is gonna love, I don't know, Frank Sinatra, and you will see the difference. They immediately relate with the song, and they immediately start telling you stories about this. Use redirection by attracting the patient attention to promote communication. The patient is unable to perform tasks when asked. Show the patient what needs to be done, or provide cues as reminders of how to perform the task. When possible, explain and demonstrate the task that the patient is asked to perform. Restlessness may indicate urinary retention, pain, infection, or hypoxia. So that's something else that we need to observe in the behavior of the patient. Pharmacologic management, psychotropic drugs have been prescribed to help control the signs and symptoms of associated mental behavioral health problems, depression, anxiety. Cholinesterase inhibitors are drugs approved for treating AD symptoms. They work to improve cholinergic neurotransmission in the brain by delaying the destruction of acetylcholine by the enzyme cholinesterase. This action may slow the onset of cognitive decline in some patients, but none of these drugs alters the course of the disease. That's very, very important to understand. The drugs are going to delay the progression, but they are not going to stop the course of the disease. In some cases, cholinesterase inhibitors may improve functional ADL ability. Examples include donepezil, which is your Aricept, galantamine, and rivastigmine. So we know that acetylcholine functions as a neurotransmitter and as a neuromodulator in the brain, playing an important role in arousal, attention, memory, and motivation. I found this video because it's important to understand how this process, the medication works. Okay. And I love the channel too. Let's see.
Once the postsynaptic membrane has been excited by the neurotransmitter, what makes it stop? Reuptake pumps and breakdown enzymes. That's what we'll talk about all the time in pharmacology. So to get neurotransmitter out of that synapse, it either has to be pumped out or the neurotransmitter has to be broken down. So once the postsynaptic membrane has been excited by the neurotransmitter, what makes it stop?
So I just want to say that he's explaining how the acetylcholine is going to be transmitted from neuron number 1 to neuron number 2 through the synapse, and what is happening in the synapse. That's that space between neuro 1 and neuro 2. Okay.
Here's my cartoon of reuptake pumps. We're just quite simply taking the neurotransmitter and pumping it back into the pre- and postsynaptic membrane where it can be recycled. Another way to get neurotransmitter out of the synapse is enzymes that just break the neurotransmitter down. Acetylcholinesterase is an essential enzyme to understand to talk about autonomic pharmacology. Acetylcholinesterase breaks down acetylcholine in the synapse. So think about it. It's the garbage disposal that's breaking down the acetylcholine instantaneously. So if we block acetylcholinesterase using drugs called cholinesterase inhibitors, we're going to end up with more acetylcholine in the synapse. Because of that, cholinesterase inhibitors are indirectly cholinomimetic. Blocking acetylcholinesterase leaves more acetylcholine in the synapse, so cholinesterase inhibitors are cholinomimetic. So cholinesterase inhibitors block the breakdown of acetylcholine. So cholinesterase inhibitors leave more acetylcholine in the synapse, therefore they are cholinomimetic. Cholinomimetics, which include cholinesterase inhibitors, will be used in the treatment of not only myasthenia gravis, but Sjogren's syndrome, bowel or bladder atony, that means without tone, weak bowel, weak bladder. We'll give them cholinesterase inhibitors or cholinomimetics to stimulate bowel and bladder. Cholinesterase inhibitors are used in the treatment of glaucoma. Cholinesterase inhibitors will be used in the treatment of anticholinergic toxicity, otherwise known as belladonna toxicity. We'll use cholinesterase inhibitors in the reversal of paralytic agents. We'll use cholinesterase inhibitors in the treatment of Alzheimer's disease and in the treatment of Parkinson's disease. Cholinesterase inhibitors typically end in the word stigmine, so physostigmine, neostigmine, pyridostigmine. These are cholinesterase inhibitors, and they have all sorts of interesting uses as cholinomimetics. Edrophonium is tensilon. It's used in the diagnosis of myasthenia gravis. It's a cholinesterase inhibitor, a cholinomimetic drug. Rivastigmine, Azexalon, galantamine, Razidine, Tacrine, Cognex, Diazepam, Aricept. These are all used in the dimension of either Alzheimer's or Parkinson's disease, more commonly Alzheimer's disease. And again, these are cholinesterase inhibitors that we'll talk about during central nervous system pharmacology. Insecticides are cholinesterase inhibitors, usually irreversible cholinesterase inhibitors. Military nerve gas is a cholinesterase inhibitor. And so military men and women who are at risk for being exposed to nerve gas carry atropine and cholinesterase reactivators in a syringe in the treatment of cholinergic toxicity in the case of military nerve gas. People who work around insecticides, sometimes somebody will be exposed to an enormous amount of insecticide. Those are cholinesterase inhibitors, and we'll give them atropine and cholinesterase reactivators to treat them for the cholinergic toxicity.
Okay, thank you so much. This was a great video, and I'm so happy to found this channel. You can go ahead and look for more explanations. This doctor does a great work explaining. So let me tell you something. You need to understand how the neurotransmitter is basically traveling from one neuron to another, and what is the problem in the synapse. When you understand this, you're going to understand the mechanism of action of the medication and also the pathophysiology of the disorder. And let me tell you that in NCLEX, the pathophysiology of the disorder, these questions are very common. You can see, for example, in Alzheimer's disease, the acetylcholine is produced, select all that apply, no? Because acetylcholine travels from one neuron to another, and there is an activation of the enzyme, This is one option. Option B, The neurotransmitter jumps in weird ways from one neuron to another, and so you need to be familiarized. Once you understand how the pathophysiology and the mechanism of action of the medications are, you are going to be answering those questions very fast and you are not going to be confused. This explanation basically is kind of covering myasthenia gravis as well, okay? And we're going to talk about that in a few minutes. Okay, so nursing safety priority, that's good to know. Teach the family to monitor the patient's heart rate and report dizziness or falls because cholinesterase inhibitors, which is your donepezil or Aricept, can cause bradycardia. Therefore, they are used cautiously in patients who have a history of heart disease. Let me remind you, you are the last step between the doctor's prescription and the patient. If you notice in your shift the patient is having a drop in blood pressure, the pulse is different from baseline, and the doctor just ordered Aricept, right? Then you can stop the medication. Please don't play the role of just going to work to your shift and just administer medication without knowing what is it about. That's why I strongly suggest you to study from the book and review your material. You see, all these details are not in your PowerPoint. That's why I'm going through. And don't tell me, Professor, you didn't teach that. Yes, I am teaching whatever is in the book and more with all these videos. Please review your material. Okay, memantine is a N-methyl D-aspartate receptor antagonist. It's another type of medication. Okay, it's a newer class of drugs. So these drugs blocks excess amount of glutamate that can damage nerve cells. It is indicated for advanced AD and has been shown in some patients to slow the pace of deterioration. So you are not going to give this on the early stage, okay? Memantine may help maintain patient function for a few months longer. Some patients also have improved memory and thinking skills. This drug can be given with donepezil, a cholesterol inhibitor. So you can give both of those medications, right? Because the mechanism of action is different. One is a receptor antagonist. This one, memantine, works in the receptor, while donepezil is a cholinesterase inhibitor. It's working on the protein that is breaking acetylcholine. You see? Now that we know how it works, we can see which medication is for what. So both they can be given together because they work in different areas. In 2022, the U.S. Food and Drug Administration gave fast track approval for aducanumab, the first new drug for AD in 20 years. It is an amyloid beta directed monoclonal antibody that is proposed to treat AD by reducing amyloid plaques. It's another area, right? That there is no relation with this medication and the previous two that we mentioned, the receptor antagonist and the cholinesterase inhibitor. So this is working on the amyloid beta. Directed monoclonal antibody that is proposed to treat by reducing amyloid plaques. Controversy surrounding the FDA approval based on clinical data being less than robust and the exorbitant cost of the drug. So it's very expensive, and in the studies, in order to approve this drug, they were not including as many patients as usual evidence-based study should have, right? They need to have like 2,000, 3,000 different populations and different stages, right? So that's why it's controversial. Some patients with AD develop depression and may be treated with antidepressant, like we mentioned before, the SSRIs, sertraline, psychotropic drugs or neuroleptic drugs should be reversed for patients with psychosis that sometimes accompany dementia, such as hallucination or delusions. However, in clinical practice, these drugs are sometimes incorrectly used for agitation, combativeness, and restlessness. Again, nurses, you are the last step between the doctor and the patient. You should know exactly what are you giving to the patient. Therefore, most geriatrics recommend that they be used as a last resort and with caution in low doses for specific mental behavioral health problems. So now we're going to jump into factor number 2, preventing injuries or falls. Many patients with dementia tend to wander and may easily become lost. Teach the patient the importance of a patient identification badge or bracelet. The badge should include how to contact the primary caregiver in an inpatient setting, for example. Check patients frequently and place them in a room that can be monitored easily. Place them in a room that can be monitored easily. The room should be away from exits and stairs. We know that. Restlessness may be decreased if patients are taking for frequent walks. If patients begin to wander, redirect them. For example, if patients insist on going shopping for clothes, redirect them to their closet to select clothing that they will not recognize as their own. So we have another table: prevent and manage wandering in hospitalized patients, provide appropriate supervision. You can divide the supervision with your nurse assistant, or the nurse can put the computer in front of the patient's room. Place the patient in an area that provides maximum observation, but not in the nurse's station. And I have kind of an objection on this. In my experience, this type of patients, we usually, but it all depends on the team of nurses that you're working with, right? Sometimes it's beneficial for the patient to be close to the nurse station. We put a sofa chair there and we give the patient activities to do. We can bring books, we can bring I don't know, puzzles. Maybe we can collaborate with the patient and start singing with them. But if you see that the unit is very busy and there is a lot of activities, for example, transferring patient to other procedures, admissions, discharge. This is too much activity for the patient to be there, right? So if you see that the unit is kind of slow and is quiet, you can bring the patient. So you have to analyze. Keep the patient away from stairs and elevators. We know that. Do not change rooms to prevent increasing confusion. Use reorientation methods or validation therapy as appropriate. So keep the patient busy with structured activities, puzzles, board game, art supplies. Computer games are often appropriate, right? Music and art therapy are also helpful to stimulate cognition. Sometimes patients they cannot recognize objects or situations as harmful. This is very important. So remove or secure or potential dangerous objects like knives, drugs, cleaning solutions. Patients are often unaware that their driving ability is impaired and usually want to continue this activity even if their driver license has been suspended or they are unsafe. Automobile keys must be secure, but the patient should be told why they were taken. Patients in the community or an institution may also experience falls as their disease progresses. Assistive technology can assist in keeping patients safe. So, late in the disease, the patient may experience seizure activities. You see, all these facts are not listed in your PowerPoint, and you need to be aware of this. Many of these are going. Many of these facts are going to come in your NCLEX exam in the stem of a question. So you need to be familiarized. Teach caregivers what action to take when a seizure occurs to prevent injury. In late stages of the disease, some patients may also become severely agitated and physically or verbally abusive to others. So you need to talk to them in a calm way, try to handle the situation. Some patients at this stage, they are going to refuse to take a shower or to take a bath, and staff that is not prepared to handle, to manage these patients are going to give are going to label the patient as difficult, hard to manage. So in some facilities, they are going to tell you, you know what, let's put a restraint. I've seen it. I've seen this. So you have to be compassionate. You need to talk and communicate with the patient. I'm sorry, you are upset. I know it is hard. I will have someone to stay with you until you feel better. You have to teach the caregiver, if the patient remain agitated, to probably leave the room after explaining that you will return later. You need to try the patient to calm down. Okay, you don't want to make the situation worse. You need to handle this in a professional way. If IV access is needed, the catheter or cannula is placed in an area that the patient cannot easily see, or it should be covered. This is very hard, right? Sometimes you put the IV and then you cover this with a specific fabric. But when the patient is agitated, they are going to start removing everything. So you have to keep an eye and try to be understandable, and try to cope and validate the patient's feelings, right? That's the best part and the most important. Important fact number 3. So, preventing elder abuse. The patient with moderate or severe dementia requires continued 24-hour supervision and caregiving. Severe cognitive changes leave the patient unable to manage finances, property, or personal care. The family needs to seek legal counseling regarding the patient's competency and the need to obtain guardianship or a durable medical power of attorney when necessary. And that's good to know. This is NCLEX legal aspects of nursing care. This is very important, okay? Patients who are cared for at home are at high risk for neglect or abuse. And I've seen this when I used to work in my first job in home health care. As a home health supervisor, I've seen a daughter who left the mother in a two-family house. She was by herself living there, and I was trying to prepare food for her, and there was no food in the refrigerator. Only a CNA taking care of the patient for 4 to 6 hours per day. The Joint Commission requires all patients to be assessed for neglect and abuse on admission to a healthcare facility, and patients with early dementia may not report these concerns for fear or retaliation. Asking questions such as, who cooks for you? Do you get help when you need it? Do you wait long for help to the bathroom? May be less stressful for the patient to answer. And that's true, yeah. I was reported, I got the report that whenever the CNA arrived there, the home health assistant arrived to the house of this lady. Basically, she need to clean after the lady, right? And she has to change the bed sheets, and it was a disaster. Very, very difficult situation. Family caregivers include relatives, significant others, and neighbors who provide the majority of home health care. These individuals often report negative impacts on their health from their role as caregiver. Yes, it's not easy, and not everybody can do this job. That's why I emphasize compassion and the we need to identify the proper caregivers. If we don't want anybody from an agency, we need to identify who in the family has the skills to take care for these patients, right? Including the caregivers are going to suffer from anxiety. However, a 2020 study showed that providing caregivers with education and promoting their physical and emotional health had several positive outcomes, including decreased anxiety. We need to teach family caregivers to be aware of their own health and stress levels. Some caregivers find that eventually they need to place their loved ones into a respite setting or unit so they can re-energize and prevent or manage spiritual distress. And this is going to happen at the beginning. If they feel that they cannot manage their stress, they are going to put the patient in respite care. And then after that, the next time is going to be to transfer the patient to a long-term care facility. It always ends like that. It's not easy. Black and Hispanic individuals have a greater risk for developing AD, and after it develops earlier. These groups are known to be very family centered and tend to care for their family members. It's true, more than home when compared with whites. As a result of these values and beliefs, an increase in family caregivers is expected as the number of older minority adults increases dramatically within the next 20 to 30 years. Factor number 4, this is the last one. Managing symptoms at end of life. AD is a terminal illness that can cause pain and other symptoms requiring palliative care. Therefore, the expected outcome is that the patient achieve adequate pain management and is comfortable as possible during the end of life. And I used to work in hospice, and we have a lot of terminally ill patients with AD, and it was very painful, but we managed to provide appropriate pain management for them. See the legal ethical consideration box. This is good for you to review, and because all this is, you're going to see this in the NCLEX as a nursing care, legal aspects of nursing care. Nurses need to educate family caregivers about the patient needs for palliative care to promote comfort and quality of life during the end of life. AD experience pain in the last few months of life but are not able to verbalize their experience. Yes, of course. Many older adults have arthritis or other chronic diseases that can cause persistent pain. We have to monitor this dyspnea. Remember your ABCs: airway, breathing, circulation, so dyspnea, behavioral issues, infections, cachexia. Assess pain in non-communicative patients, including the pain assessment in advanced dementia instrument that they will teach you how to use this tool in your settings. Ensure that patients receive round-the-clock acetaminophen for mild to moderate pain. Patients who have more severe pain may need opioids such as oral concentrated morphine administered sublingually. There are nurses, I've seen nurses that they are given the acetaminophen every 4 hours. But if the patient reports that they are still having pain, they go and they explain to them, I cannot give you more because I already give you your dose, right? And they don't communicate this to the doctor. I've seen nurses like that. You need to be trying to assess. You need to provide comfort to the patient in all ways. Infections, especially urinary tract infections and pneumonia, you need to monitor that. So how do you monitor urinary tract infection? The smell of the urine, probably the color of the urine, right? If you see blood, right? The patient is developing fever. okay? Because the mental status is going to be altered already. So that's the other way to assess for urinary tract infection. Aggressive and psychotic behaviors, including delirium and hallucination. If possible, antipsychotic drugs should be used as a last resort. We know that, and we know why as a last resort. Let stage of AD forget how to chew and swallow, and this is the sad part of this disease, and therefore giving them food and fluids is often not possible. However, use of feeding tubes to supply hydration and nutrition is contraindicated at end of life, even if the patient has cachexia due to life-threatening complications. And this part is very sad because the family members are going to ask you why you are not giving food or fluids to my family member, even through the IV, right? And you have to let them know and let them understand why are the reasons. Care coordination and transition management, home care management. You have to teach the family members to appropriate community resources to obtain basic needs. Whenever possible, the patient and family should have a case manager who can assess and is going to provide you with all the information for resources. In the early stage of AD, healthcare agencies have adult medical daycare centers or memory care units. If the patient requires 24-hour care, they may be placed in a memory care unit of a long-term care or assisted living facility. Also, you have to know where are respite care available for families. Remind the family that respite care is for a short period and is not permanent placement. Self-management education. We have to train not only the family members, but we have to give them appropriate training related to seizure and how to protect the patient from injury, and to notify the primary healthcare provider immediately if the seizure is prolonged or if the patient's seizure pattern changes. Emphasis on place on the need for the patient to have a established exercise program to maintain mobility for as long as possible, not to prevent complication of immobility. And also the family and the caregiver must remember that to take special precautions to maintain the patient safely at home is a must. The environment must be uncluttered, consistent, and structured. All hazardous items, cooking range, and oven power tools are removed, secured, and locked out. Okay. Healthcare resources, remember and refer all families to their local chapter of the Alzheimer Association. Teach the family to enroll the patient in the Safe Return Program, which is a U.S. government-funded program of the Alzheimer Association that assists in the identification and safe, timely return of people with dementia. Yeah, I know this topic is long. I know, I hear you, I can feel you. But if we follow your PowerPoints, you are not going to be ready with all these aspects. And also, again, we need to realize we are blessed to have all these resources in US. Some of us are coming from countries that they don't even know how to provide a specific care right now in our countries. I don't think in my country at least we are going to have a Alzheimer association. I don't think so. So we need to know about these facts. Behaviors for patients with Alzheimer's disease at home. Review all these suggestions and facts that I'm pretty sure we already talked about this through the entire chapter. And in the advanced, remember, and in the advanced stage of the disease, the patient may need referral to palliative and possible hospice services for total care. Yes, I know. I've been working in hospice with this type of patients. So at the end, Our evaluation should cover maintaining memory and cognition, remain free from injury, manage caregiver stress and strain to prevent elder abuse, and manage pain and other symptoms at the end of life to promote comfort and quality of life. Thank you so much for your attention. When we come back, we are going to review Parkinson's disease.